patient, but anyway, because with thrombology patient anyway at the point of time, and then because like for the good people, CTP and making clear. I was like asking, like the injury है, we have to identify like this a case not going to kill you definitely. We have to identify what is it. If there control this thing, then we can. What is all this acute or? The expecting is there. So when Dr. Chandan comes to tell the stories and discuss and iron out. देखो बेटा आपका प्रेजेंटेशन तो अच्छा था है ना आपके स्लाइड्स अच्छे थे यू हैव डन गुड रिसर्च है ना एंड यू हैव पुट द साइटेशन पर थोड़ा सा आपका सब कुछ अच्छा था खाली यू नीड टू वर्क ऑन योर ओन माइक्रो है ना तो थोड़ा सा उसमें आप काम करें थोड़ा मोनोटोनस सा था दैट यू नीड टू इम्प्रूव और दूसरा आपका लेफ्ट हैंड ज्यादातर पॉकेट में रहता है लेफ्ट साइड है ना so that is important no? So nobody will tell you in your life मैं सही बोल रहा हूँ कि नहीं गलत बोल रहा हूँ क्या है तो मैं भी रखता था राइट हैंड मेरा राइट जेब में रहता था ठीक है तो किसी ने पॉइंट आउट किया मुझे नहीं I took out that and never went back ठीक है so work on your micro teaching skills otherwise you are really very good
Good morning to Anima. I would like to start my presentation with the case scenario. A 54-year-old lady with uncontrolled diabetes came to ED with complaints of a blister formation on the right foot 1 week back, followed by a swelling of the right foot in the past 5 days. It is associated with fever and redness of the lower limb. Her respiratory rate was 22 and her saturation was 96 with a pulse rate of 120 and a BP of 94/60. She was febrile with a total count of 22,000. What are the differential diagnoses for unilateral lower limb swelling? What is the focus finding of this patient is shown here. What is it and what is the management? I will discuss this in the further slides. Here is another case scenario. A 25-year-old presented with a 3-day history of progressive difficulty of swallowing, odynophagia, dysphonia, trismus, extraoral swelling and pain initiated, and the pain was initiated in the right posterior mandible, which progressed to the contralateral side. Airway is patent. Patient can speak in full sentences. The respiratory rate was 24, saturation 94, and the pulse rate was 100 with a BP of 100/70. Patient was febrile to touch. How would you approach this patient? What is the primary emergency care that can be given? What antibiotics will be started? While the treatment was being initiated, the patient sat up and the stridor was heard. Drooling of saliva was present and the patient developed cyanosis. How would you manage this airway? What are the further surgical interventions for this patient? Good morning to one and all once again. My topic for today is skin and soft tissue infections. My moderator is Dr. Meena ma'am. I'll be highlighting this presentation by the following topics. That is, why is skin and soft tissue important? Infections important. Description of the skin, microbiology, classification, approach to diagnosis and management of skin and soft tissue infection, abscess, cellulitis, and necrotizing fasciitis. Why should we learn about skin and soft tissue in emergency? Is that in United States, more than 6 million emergency visits are due to skin and soft tissue infection. They range through a broad spectrum of diseases from a routine abscess to a rapidly life-threatening necrotizing fasciitis. It is a diagnostic challenge at presentation. The management is multi-pronged, involving both surgical and medical emergency expertise. It can precipitate common emergency in our setup like DKA, ADHF, and sepsis with epic shock. Here, here is a image of the skin and soft tissue. I'll be comparing the anatomy with the common infections. So the first layer is the epidermis. The epidermis is a thin and avascular layer. The most common infections is erysipelas and impetigo in this layer. This is the epidermis, which is thin and avascular. The next is the dermis. It consists of hair follicles, sebaceous glands, sweat glands, and the infections that are common are folliculitis and furuncle. I'll be explaining this in the further slides. The next layer is the hypodermis or the subcutaneous tissue, which contains mostly adipose tissue and vascular blood supply and nerves. Uh, Between the two, the dermis and the subcutaneous tissue is the superficial fascia. After the subcutaneous tissue is our deep fascia, then the muscle. The microbiology of skin and soft tissue infections most commonly is Staphylococcus aureus. So we know that Staph aureus is a gram-positive cocci, and in United States, most commonly it became an emergency in the late 90s due to empirical antibiotics. This caused a community-acquired MRSA. Uh, in in United States, the most common cause is MRSA, and after that is a methicillin-sensitive Staph aureus, followed by beta hemolytic streptococci. In our institute in AIMS New Delhi, there was a study done in skin and soft tissue infection in hospitalized patients, not just ED, where they found that the most common was MRSA being 38%. Most common organism was Staph aureus, E. coli, and Pseudomonas. In Staph aureus, 38% was MRSA. Actually, this is the highest in India. Other places like CMC Vellore, where they have done the study, they have found lower percentages of MRSA. Then this was done in 2004. Huh, this was recently they again then did it in 2017. The Department of Microbiology, same percentage was seen around the same massa. Then
That means you need to follow everything for the kind of first.
yes,
We must quarantine.
gram negative. So first is Staph aureus, E. coli, Pseudomonas. Then they have also found Klebsiella and Acinetobacter and Enterococci, total 5. Wherein gram negative ESBL production has also been seen in 66%. In CMC Vellore, they did a study in exclusively emergency department where they found that the blood culture was positive for staph epidermidis, cons, and followed by streptococci. And the pus culture showed mixed flora.
What is HLA-RG?
That is high level aminoglycoside resistance. So that is also, I think they are also, for gram negative bacteria, uh, they are, they calculate, find that that's,
Yeah, I don't like what that is.
this is a classification of the spectrum of skin and soft tissue infection. Cutaneous abscess, which I will explain in further slides. Folliculitis is basically the infection of hair follicle. In this picture, we can see that this is so folliculitis is infection of hair follicle. Furuncle is when adjacent to the hair follicle there's a abscess that is collected that they track down along the hair follicle and can go up to the hypodermis. A carbuncle is when there are multiple abscesses which will open up, uh, forming a sieve-like formation. They're connected to each other with the help of the superficial fascia. This is a carbuncle, which is a cluster of furuncles. Here again, paronychia is the abscess at the base of a finger, and hidradenitis suppurata is not an infection, but it's like an acute and chronic inflammation of the sebaceous gland. The skin and soft tissue severity classification is also important, especially for the disposition of the disease. Class 1 is afebrile healthy. So if patient is coming, one is pulp space infection. Uh, Class 1 is when the patient is coming with only a abscess, a patient is afebrile and healthy, we can do an incision and drainage and send the patient back home. Class 2 is patient is febrile, ill appearing, and hence we have to start the patient on oral antibiotics or IV antibiotics. Class 3 is the patient is appearing toxic and unwell, where the patient requires inpatient admission and parenteral antibiotics. Class 4 is sepsis syndrome with life-threatening infection. The first type of skin infection is impetigo. It's the infection of the superficial skin, that is the epidermis. It is classified into bullous and non-bullous type. It's most commonly seen in children. The first image is non-bullous type, wherein we can see the honey-colored crusting that is present. The second image is common in less than 2 years of age. Firstly, non-bullous type, common cause is streptococcus. Bullous type is staphylococcus. The treatment for this is restricted to only ointment, that is bupirosin ointment. Next is abscess and purulent skin and soft tissue infection. Here is the brief pathogenesis of an abscess. That is, if there's a breach in the epithelium, there's a Staph aureus or any suppurative infection. They accumulate, they organize in the epidermis and dermis area, uh, recruiting neutrophils. A pus is basically straw-colored fluid which consists of both dead and living leukocytes and bacteria. This around this pus-like substance, there is a pyogenic membrane that is organized, which consists of first the dead tissue, then the granulation tissue. Dead tissue becomes slowly with time. The dead tissue becomes fibrous, and the granulation tissue keeps growing. So clinical features, as we know, signs of inflammation is always present. That is, there will be redness, pain, increase in temperature, brawny edema will be present. A fluctuation test will be positive. And in our ED, the next management is to diagnosis is by point of care ultrasound. We can use a point of care ultrasound to see how deep the abscess is, what is the extent of the abscess, and the location of the abscess. Ultrasound is also helpful in identifying deep seated abscesses which might not have that brawny induration or signs of inflammation on clinical examination. Here it is basically an hypoechoic or anechoic cavity by with acoustic enhancement. We should, in certain regions, like we should also differentiate this from lymph nodes. We can put the color Doppler and find out that it is not a lymph node. The sensitivity of focus in identifying abscess is also high, around 96%. Uh, this is actually not clearly shown. The anechoic cavity with acoustic enhancement is present. management of abscess is management of abscess is by incision and drainage. Uh, This is actually one of the initial Latin phrases, that is, there is ubi pus ibi evacuate, that is, where there is pus, you have to let it out. And initially Latin. So first we should give a free incision after painting and draping. After giving anesthesia, a free liberal incision is given, cutting upon the skin, subcutaneous tissue, superficial fascia and deep fascia along the muscle fibers also, in order to drain out the pus accumulated. In cases wherein there are important areas associated, we must use Hilton's method. So Hilton's method is basically, we do not give a liberal incision, we should give a incision and use sinus forceps or our fingers to open up the loculi to let go of all the pus. Next, Next is one counter incision is always important in case of breast abscess, wherein the point of fluctuation is different from the most dependent part. So usually we give two incisions in cases of breast abscess or abscess which wherein the most prominent part is not the most dependent part. Uh, Another technique for drainage is using a loop drainage technique that is seen here. In order to drain the pus, we use a loop that we tie like this and allow the pus to drain over time. Post-drainage packing is debatable and not preferred. Usually, previously we used to pack the abscess after incision and drainage. Now it is not preferred. So, treatment of abscess is antibiotics. According to the 2014 IDSA guidelines, antibiotics is reserved only for large and complicated abscess with systemic inflammatory response syndrome, or which is greater than 5 centimeters with surrounding inflammation, or if it is occurring in an immunocompromised host. But there are other studies which have shown consistent benefit of antibiotics for uncomplicated abscesses. This is the most important slide of my presentation. Starting from when we suspect a skin and soft tissue infection, that is, if there is erythema, warmth, and tenderness, we first look for pus. Uh, how we look for pus? Either clinical examination by finding a point of fluctuance or by using point of care ultrasound. If pus is present, then it can either be an abscess, that is, it is a restricted to a certain area, or purulent cellulitis, wherein it is diffuse. This again will determine the treatment, because in case of an abscess, we have to drain the abscess, and the antibiotic treatment will be more oriented to MRSA cover and pus forming bacteria cover. In case of if the fluctuation test or ultrasound is negative, then it is we will treat in terms of non-purulent cellulitis like erysipelas, wherein drainage, incision and drainage is not required. So,
regarding the use of microcare ultrasound is, if it is obvious, typically it will take, right? When it is not obvious, yes, you use microcare ultrasound, right? But the sensitivity of picking up abscess in point of care ultrasound will be greatly enhanced if you can use water bath technique. Okay, especially in the extremities. Extremities. Understood? So, so the sensitivity also very is a great way. Then secondly, you can also dynamically do the correctly localization and incision and drainage by using the water
coming to cellulitis. Cellulitis is a spreading bacterial infection of the deeper dermis and the subcutaneous tissue, presenting as poorly demarcated erythema, edema, warmth, and tenderness. It will start from a cutaneous barrier disruption, that is either trauma or fissures, fungal foot infection, pressure ulcers, or eczema. The clinical features that I have mentioned above, that is tenderness, swelling, erythema, it extends rapidly to involve large areas of skin. Systemic manifestations of fever and lymphangitis. It is also seen as pudy orange appearance because caused by the dimpling of the skin. Here is a photo which shows the difference between abscess, which is restricted area, cellulitis, and erysipelas is in the superficial infection of the superficial areas, wherein cellulitis is across the skin and soft tissue. Pathology I have described here, that is dermal edema is present with lymphatic dilation, heavy neutrophil infiltration will occur around the blood vessels. In later stages, the lymphocytes will come into place and granulation tissue will be present. This is the point of care ultrasound of a cellulitis image. Here is the normal normal image of the skin, wherein you can see dermis, hypodermis, and fascia. This is a cobblestone appearance.
PowerPoint.
This image. This is a point of care ultrasound of cellulitis, wherein this is actually the dermis area. As you know, the dermis consists of adipose tissue. So the hyperechoic structures are the adipose tissue, wherein it is separated by the anechoic strands, which is the cellulitis, edematous swelling, which is this is known as cobblestone. Here is a patient from our ED. He is a young male with aplastic anemia who received an injury over the mandible area, and when we did point of care ultrasound on the left cheek, this was a I think masseter in the buccal space, and on the right cheek we can see that the cobblestone appearance was present. Huh?
Yeah. When you did it, Radhika, it was like this.
It was better. It was better.
It was better. To optimize the image. I said, the Bhavana is also important. So there are no again to the high.
This is a difference between purulent cellulitis and non-purulent cellulitis. So purulent cellulitis is again the spreading bacterial infection of the epidermis, dermis, and soft tissue, but it will always have a purulent focus. So this is a furuncle which has spread into a cellulitis, abdominal cellulitis. Wherein non-purulent cellulitis is a circumferential spread around the limb. Most commonly cause of purulent cellulitis is Staphylococcus aureus, wherein non-purulent cellulitis is Streptococcus. Pathophysiology, they say imminent internally it's given that it is mostly the toxins and inflammatory mediators that is causing the non-purulent cellulitis more than the bacterial load. Again, the point of yes. This is the point of care non-purulent. Non-purulent. New emergency we see mostly non-purulent. radiologically, we know that purulent is always associated with an abscess, that is the hypoechoic cavity present. Here it is non-purulent, that is the cobblestone appearance. According to IDSA, in non-purulent cellulitis, it is not routinely recommended for blood culture or swab cultures to be sent. Whereas in purulent cellulitis, as it is associated with the abscess, we must gram stain and culture the pus aspirate. The management also involves incision and drainage in case of purulent cellulitis. Uh, हाँ, this is like this is the I have one more photo. Huh. This is like a simple furuncle with inflammation. So we must differentiate this that this is not cellulitis. Uh, this is the furuncle which has caused cellulitis. So we have the abscess. We have to incision and drainage must be done of the furuncle, and then treat antibiotics. Huh. Because we need to know the depth of the abscess. Superficially, this. Yes.
What I say. Typically, they are common. So इसमें आप water bath technique करेंगे ना, if you do water bath technique, then it will greatly enhanced. You can also measure depth of extension of your axis. And even dynamically also you can put a anti or put a technical put also. You can live stream the whole they're going in. You can see what happens.
Erysipelas is a subtype of non-purulent cellulitis, which is most commonly seen in children. We see that it is there, unlike the classic cellulitis, wherein it's poorly demarcated. Here, there's a clear line of demarcation between the involved and not involved tissue. Millions years and positive was a common viva question after surgery. That is when the erysipelas of the face involving the pinna involves the pinna, it causes cuticular lymphangitis. But if it is cellulitis, then it will not involve the pinna. Management of non-purulent cellulitis is we will cover for methicillin sensitive Staph aureus and Streptococcus. So outpatient, we will give oral augmentin and cephalexin, which is first generation cephalosporin. Inpatient, that is in patients which are febrile, which are basically class 2 or 3, we want to give inpatient treatment, parenteral antibiotics. Then we use cefazolin and IV augmentin. The IDSA also says elevation of foot is recommended. We must always search for the portal of entry, that is the fissures between, in case of diabetic patients, fissures between the toes, treat for fungal infections there. In case of MRSA susceptible individuals, wherein there is MRSA infection elsewhere, nasal colonization, illicit drug abuse, then we should think of covering MRSA antibiotics. This is the typical purulent. That is, if there's a source of abscess that is causing the cellulitis. Outpatient is cotrimoxazole, minocycline, doxycycline. Inpatient is vancomycin, linezolid, and teicoplanin. IDSA is basically American guidelines. They haven't mentioned teicoplanin, but teicoplanin also covers MRSA we commonly use in our practice. In case there is we suspect a risk of gram-negative infections, like there is perianal abscess, abscesses near like such as perianal abscess, we can cover for gram-negative also because resident bacteria is gram-negative. Differential diagnosis is an important part of cellulitis because a lot of times we are confused whether it is cellulitis or not. Here is a table from Tintinelli. This can be easily divided into vascular type of differential diagnosis, wherein we can say status dermatitis or DVT, peripheral artery disease, or inflammatory causes like gout, miscellaneous causes like insect stings. This is a big representation of a differential diagnosis. It's helpful, you can go through it afterwards. Coming to necrotizing fasciitis. So, necrotizing fasciitis is an aggressive subcutaneous infection that tracks along the superficial fascia. So, we have epidermis, dermis, subcutaneous tissue, which is having rich vascular supply. From the subcutaneous tissue, the vascular supply pierces through the superficial fascia and supplies the dermis. So, the superficial fascia is relatively avascular. So, they say that the bacteria track along the superficial fascia and involve the infection of the dermis, subcutaneous tissue. So dermis is cellulitis, subcutaneous tissue and fascia will become fasciitis, and sometimes it will also start involving the muscle, causing myositis. So necrotizing soft tissue infection, or also known as NSTI, manifests as permanent tissue destruction, systemic signs of toxicity, high mortality. It is mainly a surgical diagnosis which is characterized by the friability of superficial fascia, dishwater exudate, and a notable absence of pus. What does it mean for necrotizing for emergency department? This infection develops very rapidly, around 1 inch per hour. So either we will see the patient diagnose immediately and go ahead with surgical exploration and the patient might survive, or that we do not diagnose and the patient will deteriorate. And this is quoted from an article. This is a high stakes for ED, as emergency physicians must work with surgeon. Because the ultimate treatment for necrotizing skin soft tissue infection is surgical. So it's our duty to start the antibiotics and immediately correspond with the surgical department for initiating treatment.
One inch per hour. Okay, that's what it said now. So that is the dictum. 1 inch per hour. हम कहते हैं ना कि लोग को और decrease survival by 10%, by 10, saying sepsis 7.5%, mortality in 1 hour. समझ रहे हो ना? ऐसे ही यहाँ पे 2.5 inch, right? Sorry, 1 inch per hour. No, progress like that. It will be pretty quick. And another important point which he said is it is cellulitis, fasciitis, myositis. तीनों layers में problem है. That is a one-liner Radhika should give. That is what the teaching part is. Micro teaching यही है. अगर आपको hammer करना ना, तो hammer like that in every slide.
This is a photo from NGM, wherein basically pathogenesis. Pathogenesis is first one type of NSTI is where a defined portal of entry. So there is a skin and mucosal breach. This can be any bee sting bite, drug injection, even varicella zoster causes the entry of organisms. These organisms will release exotoxin. This exotoxin will cause platelet and leukocyte aggregation in the capillaries. Again, providing an anaerobic region for the bacteria to grow. Then this will slowly spread downwards, causing bullae, ecchymosis, then start to involve the hypodermis region, and again causing vascular thrombosis. This is when there is no defined portal of entry. That is common in group A streptococci, wherein if there is a deep tissue injury and it is associated with transient bacteremia, this provides an opportunity for the transient bacteremia to move into the cause myositis. Then the infection moves downwards to upwards, causing after the exotoxins are released, again causing venous occlusion, then arterial occlusion, thus causing ecchymosis bulla. Uh, this is the
So
classification.
Radhika, one is that you have a point of entry and go from superficial to deep. The other one you don't have portal of entry from deep to superficial. That is how it comes. अब तो पहले वाले में आपका स्टैप कॉमन है, इसमें गैस कॉमन है.
In
First
case,
one, portal of entry जाने जिसमें कौन सा है common.
actually, sir, NSTI microbiology is different. I will come to it. So, NSTI, we can classify, this is a table which classifies based on cause. So the first four causes is there is a trauma. So there is either major penetrating trauma like crush injury, penetrating injury like civil war injury, that is the historical cause of gas gangrene, which is also still common in India. The minor penetrating injury or a minor non-penetrating injury like muscle sprain, which is muscle sprain. Then there is that is the mucosal breach, any genitourinary gynecological surgery, GI mucosal breach, or the skin breach. A skin breach that is varicella insect bite injection drugs. We see many varicella cases which will end up leading to cellulitis in baby. In immunocompromised patients like diabetes with peripheral vascular disease, cirrhosis, neutropenia. Next slide I have elaborated. So the first type one of necrotizing is polymicrobial. It involves more than one type of bacteria, that is anaerobic species, that is Bacteroides, Streptococcus, Enterobacteriaceae, which is E. coli, and even aerobic bacteria. So a combination of anaerobic and aerobic is seen. Uh, in, yes, type. Yes. Monomicrobial is group A streptococci, that is one microbe, that is a group A streptococcus, also known as flesh-eating bacteria. There is type 3 and type 4. Type 3 is a rare cause of necrotizing fasciitis, that is, in this case, I have highlighted gas gangrene. Gas gangrene common causes Clostridium perfringens in traumatic injury, spontaneous septicum, gynecological is sordely. Uh, so pathogenesis of the disease, we should highlight the pathogenesis in case of monomicrobial, that is group A streptococcus and gas gangrene. So monomicrobial is, we know M protein is the super antigen. Super antigen is an exotoxin which hyperstimulates the immune system. And pyrogenic exotoxin, this is the method of pathogenesis of injury, which will also cause toxic shock syndrome. In case of gas gangrene, lecithinase that is also alpha toxin and beta toxin is the pathogenesis of gas gangrene. Basically, platelet destruction, hemolysis, all the action on the capillaries will produce thrombosis, a microthrombosis in the soft tissue, creating an anaerobic environment for further development of the bacteria. Uh, the most important differentiating point of all three is whether identification, and that is diagnosis. That is, gas is present in case of polymicrobial and gas gangrene. No gas is present in monomicrobial because it is not. It's an aerobic bacteria. It's not anaerobic. Anatomical location.
So clinically, if you know how often they present gas is
In
the gas in soft tissue, only it is gas gangrene, correct? How many, how often you see polymicrobial?
polymicrobial gas and tissue is less. It is less common. I don't have the statistics.
And even in gas gangrene, how many patients have gas? no gas in the tissue. That's why you actually cannot differentiate
Yes, sir.
clinically this type of thing.
Yes, sir. Yes, sir. Have some more slides regarding radiological investigation. Ye- No, not a. Um, yes, sir. So anatomical location of polymicrobial is Fournier's gangrene, Ludwig's angina, any involving genitourinary space, oral mucosa, whereas type 2 is involves the extremities of skin associated with non-penetrating trauma. In case of gas gangrene, is traumatic deep penetrating injury. Epidemiology, it is associated in immunocompromised patients. Uh, in necrotizing type 2, it is all age groups, healthy individuals with minor non-penetrating trauma. This is also an important part that associated finding of type 1 is usually septic shock. Complications of necrotizing fasciitis. Type 2 is capillary shock syndrome or toxic shock syndrome, which is associated with vomiting, diarrhea, and diffuse erythema. Um, Many patients will come to ED presenting with these symptoms, but not as sometimes some gynecological or injuries cannot be easily identified. They will present with these symptoms, such as vomiting and diarrhea. Gas gangrene is associated with septic shock and rapid. This is a photo of gas gangrene. Now coming to the clinical features. So the clinical features, the soft tissue infection, we know that there's a soft tissue infection, edema, erythema, warmth, associated with systemic instabilities, that is class 4 SSTI, that is fever with hemodynamic instability. Now, we know that we should consider an STI. The misdiagnosis rate in case of ED is up to 96% because there is an absence of hard findings at presentation. In the hard findings of MSTI is severe pain that is out of proportion, crepitus, skin discoloration, necrosis and foul smelling wound discharge, and rapid progression of clinical manifestations. So, along with soft tissue infection and systemic instability, if we have hard findings, these three hard findings, then it is guaranteed that we should uh, take the patient to surgical exploration. If not, then we have further diagnostic tools. It is said in this paper that to improve diagnostic ruling out capability, as the mixed diagnosis rate is very high, like as we think of thunderclap headache to equate to subarachnoid hemorrhage, whenever we see certain case like diabetic foot infection or a Fournier's gangrene or odontal dental infection, we must always think of necrotizing soft tissue. This is the sensitivity of on presentation of swelling, tenderness, erythema in ED associated with crepitus, clinical signs of bulle skin necrosis and crepitus. This was a ALL patient who came with fever and pain in his both lower limbs. So he was in some. This mask. I just wanted to show that pain is out of proportion. Actually, this was when basically this was the he was having pain in both lower limbs. So patient was a 45-year-old male, long case of ALL, follow-up of hematology, came with fever. Fever history since 3 days with pain in both lower limbs. So I just wanted to show that Basically, basically there is no like on clinical examination, there is no lesion that is present. So even just on touching his both eyes, he was in so much pain. After ultrasound, it was found that he was not having he was having pyomyositis. Yes, sir. It was little confusing, but we collaborated with the radiology also. They found that he had pyomyositis. This is a table from NEGM, which basically shows again the same thing that I said, that swelling, erythema, pain, that is basically soft tissue infection with systemic signs. Then, if there are soft tissue infection, systemic signs mean we can go forward with radiological investigation, but this means that it is NSTI. If there are no systemic signs, then we will suspect other soft tissue infections like cellulitis. Erysipelas. Next is the laboratory. The systemic signs can be investigated by laboratory diagnosis by a this laboratory risk indicator of necrotizing fasciitis. A score of more than greater than 6 should prompt further evaluation for imaging. That is C-reactive protein, W, hemoglobin, sodium, and creatinine glucose. Radiologically, the sensitivity of point of care ultrasound is high. It is around 88%, but MRI is 100%. This is the focus finding of necrotizing soft tissue infection. That is a subcutaneous thickening, air, and free flowing facial pain. So that is abbreviated as STAF. Uh, so this is the subcutaneous air present. Uh, there is a sub. This is the cobblestoning which is seen. Cobblestoning, that is the cellulitis associated with the subcutaneous air. Here is the subcutaneous the facial fluid and the thickening that is seen.
So you see that the vertical white line is here.
And
It's appearing the vertical like a V line. But if you see, that is because of the air water interface. So that means there is a fluid also around there. समझ रहे हो ना बेटा? हाँ, वो जो arrow जो लगाया ना लगा. So that is like a imagine a V line. तो आप ध्यान में देखते हो. Now you see, here. So that is V line. Why do you say? Because of air in the alveoli and water in interface. Na? Due to edema, due to say pulmonary edema or due to pneumonia. So here you see the air-water interface. There is some amount of water or fluid there, and plus there is a gas. That's why it is creating that interface. Very interesting. You see this other arrow, a lot of white lines are also there. That means there are pockets of air there in a patient. Or here the third C part here, you can see anechoic shadow. That is the fluid patient. Right? And plus cobblestoning, which Radhika has shown on the B part B. Cellulitis, as you said, cellulitis, fasciitis, and ठीक है ना? itis लगा दो तीनों, ठीक है?
focus finding of again subcutaneous facial thickening is seen here. Again, this is a X-ray finding of gas gangrene that we can see air present in the soft tissue, and this is a CT with a gas present in the muscular fascia. Now, the management part, that is, once we suspect that this is necrotizing soft tissue infection, then we should go for a surgical exploration. Surgical exploration here is a mode of diagnosis, even an ED physician can do it. It is not the complete management. Surgical exploration is also sometimes called as the finger probe test, wherein after putting local anesthesia, a 2 centimeter incision is made, and we must explore the soft tissue infection, that is the crepitus, necrosis, or bulla that is present. Here we see that the facial layers easily split apart. Dishwater drainage is seen. That is, this dishwater fluid is there, and there is absence of purulence, and the fascia may appear necrotic. Why we should do the surgical exploration is that we will decide whether it requires aggressive debridement or amputation. To take the specimen for gram stain culture, that is both anaerobic and aerobic, and pathological evaluation. If the infection is near vital structures, then we must immediately do a surgical exploration. After surgical exploration, we will move on to the debridement. So time to debridement, uh, the survival is significantly increased in among patients to surgery within 24 hours and higher if done within 6 hours. So preferably it should be done within 6 hours. And re-inspection and debridement should be done continuously every 1 or 2 days until the necrotic tissue is no longer present. Negative pressure devices can also be used. Historically, they have suggested that in case of anaerobic cellulitis, we must go for aggressive debridement, and in case of gas gangrene, amputation is recommended. Antibiotics for necrotizing fasciitis, uh, anti-MRSA cover, and anti-gram negative cover. For stable patients, we will go for augmentin and ceftriaxone, metronidazole. So this will cover gram negative species. Gram negative species is piptas and meropenem. So they say that in settings wherein there is a high local prevalence of ESBL producing gram negative bacteria, it is preferred to give meropenem or carbapenem. To cover anti-MRSA, we will give vancomycin teicoplanin. All of this we should add antitoxin antibiotics, which is clindamycin or linezolid. According to IDSA, we must treat antitoxin treatment should be started only when we have documented gas infection, but that is in Western countries wherein they have rapid tests for group A streptococcus. We can start in our setting. That is antibiotic.
Rapid test, or is that now? I don't know. You're the best person to tell. अभी बोला ना?
There was a sentence written.
No, no, sentence. It is written. I don't know. You're the best person. You're the master of the game. Final year. Take care. So you find out at the not even. What you tell us. The way to level up.
Antibiotic treatment we should follow surveillance sepsis campaign. We should keep in mind the dilation effect in third spacing present in necrotizing soft tissue infection, and these patients will most commonly also have hypoalbuminemia. IVIG should be considered in patients with a type 2, that is group A streptococcus, uh, and hyperbaric oxygen therapy can also be. Yes. It, yes, sir. It's not.
If you need to chair
some studies are showing that it is helpful, some are not. Yes. Yes, sir. There was a meta-analysis in 2018, but from what I have read is that it is mostly on non-randomized trials, so it is not definite.
Not definitely.
So that's why they haven't come to a conclusion.
So
Like,
you can say that because the statement you write, people will think that yes, this is the standard of care. And you say that it is not standard of care, people have tried.
right,
You can say like that. Say बहुत सारे therapies we try now. So you know, class one. So you say nobody is not a class one. Based on this study, they have tried if IBID and hyperthyroidism. That we know the patient are pretty sick to undergo a hyperthyroidism.
take home point is this slide. Basically, that whenever we take home point is first we should recognize a soft tissue infection. We must differentiate purulent and non-purulent. This will guide our antibiotic treatment. Then next important point that we should remember is the diagnostic imaging in skin and soft tissue infection. Abscess is hyperechoic cavity with acoustic enhancement. Cellulitis is cobblestone, and necrotizing fasciitis is subcutaneous thickening with subcutaneous thickening of fascia, air, and fluid present.
I just had a question. So what? That got abscess, cellulitis, purulent and non-purulent. Then you've got necrotizing soft tissue infection, which basically has a permanent tissue destruction, requires surgical plastic. And in that slide only I told that basically necrotizing soft tissue infection are cellulitis, myositis, and fasciitis. So I want to ask, like, cellulitis is basically a necrotizing soft tissue infection because the difference is
Necrotizing infection can involve skin and soft tissue that will become cellulitis, fasciitis, and myositis.
so, but if it's a necrotizing soft tissue infection, it has to have all three. That is what you're saying.
No, it does not have to have all. Because there are there is documentation that because it's a progressive disease, so there are some.
Beyond that, frustration
It is progressive, rapidly progressive. 1 inch per hour.
So, when to suspect it then? Because you say that it's the primary response here, that is only one diagnosis. The one diagnosis is right.
When if any cellulitis, that is any soft tissue infection, that is either cellulitis, erysipelas, or any of that, is associated with systemic signs, then we should start systemic signs and then say out of yes, sir, this high factor.
what was LSPI was a competitive and like lot of it's antibiotics. So how do you work
अपने अल्ट्रासाउंड किया बड़ा आसानी से पता लग जाएगा बड़ा डायग्नोसिस नहीं है बेसिकली आपको पेन और स्ट्रेस नजर आ गए सेलुलाइटिस आप कह रहे हो सेलुलाइटिस और इसमें क्या है अगर तो हम कर और उसका खाली दिख गया और कुछ भी नहीं है ये आउट ऑफ प्रोपोर्शन नहीं है ठीक है ना उसके साथ पेशा भी इन्वॉल्व हो गया वो तो पहले ही सब and how do you say somebody said how do you make out facial thickening very easy you need to compare with the normal size and do for the normal size फिर आप normal size ये बार बार इंडस्ट्री अल्ट्रासाउंड भी करते हैं ये तो समझ नहीं पाएगा पहला बार ठीक है हाँ तो have a habit of seeing fascia muscle you know सारा देखो और फैट कैसे दिखता है non वो भी था हाँ तो काम करके देखा
This is now preferred. How much?
क्या कह रहे हो राधिका व्हाट द क्वेश्चन
Drainage is now continuous drainage instead of just keeping the cavity open. We should insert a loop. Any, I think any. Yeah.
ये है एडवांस अगर सारे सारे कस्टमर देखें उस ट्राई हो गया फिर वहाँ से नहीं करते
Specific area, I'm not sure.
Plus minus we already want that one. Yeah.
ये
Most important चीज है
gram negative cover I or environment plus antitoxin like substitution yes sir amoxicillin with 10 hours.
Slides, the another good presentation you have made slides where there are two comments. One is that when you are actually highlighting some point in your slide, you have made it black and it is in capital letters. So it is better to use a different color, maybe a red color as a highlighter. And sentence case or two. You don't need to put capitals in that, right? So that is one. Second is if you see some slide, you have put the tables. see on the footnote verbatim, the same thing which is there in the table is already there in the slide. आप देखेंगे पीछे एक slide एक जाके देखिए अपना. So one should not do that because so then people will think you are totally copy pasting the tables. Understood? You got my point what I am saying. On the footnote there is a sentence, a long sentence is written, which is of no value for anybody. In your slide. What your point? है ना? और जाओ यहाँ एक बड़ा सा टेबल था हमारा लंबा सेंटेंस देखिए
This one.
क्या लिखे ना now you see नीचे लिखा हुआ है it has no value for anybody understand so there is no need to when you have long tables like this ना तो copy paste करना भी तो है तो ये नीचे वाला मत करो right otherwise it gives a wrong impression to the listeners. Otherwise, it was a very good presentation. I really enjoyed. Again, the previous presentation, he has used a lot of pictures. For skin and soft tissue, the topic itself demands that it has to have a lot of pictures. And he used algorithms and the thing. So I think the previous presenters, others can learn that wherever there is requirement, we use 6,000 words. Right? Just explain that further.
Video on
Just show.
fingerprint test is surgical, also called as surgical exploration, is a diagnostic test wherein over the necrosis or the site of infection, we give local anesthesia and make an incision and of 2 centimeters, approximately 2 centimeters, and we will probe our fingers within the fascia to feel for the skin, fascia, and the subcutaneous tissue. In this test, we must feel for that the facial layers easily split apart. We should see for the dishwater fluid and the absence of pus, and also that the color of the fascia also can be noted, whether it's gray or necrotic. And from this, we will decide 3 things. One is we should get the tissue for diagnostic purposes like culture, anaerobic culture in gram stain, and also decide whether this requires aggressive debridement or amputation can